Thank you. That was very nice. So in addition to the work that I do in the medical school at Michigan State, I also work as a clinical ethicist, and I wanted to explain that a little bit because I bet almost none of you know what that means. So I work in a hospital. I sit on the ethics committee, but I also take call. So a physician or a nurse or really anyone in a hospital can call anytime they feel like they're having an ethical dilemma or an ethical challenge arises. So this could look like, the patient is denying any treatment whatsoever. We think this treatment would really help. Are they really allowed to say no? And so we might review that case. Often it's the patient or their family is just asking for things that we don't really want to provide. Are we allowed to ever say no? So those are the kinds of consults that I get, and a lot of them involve end-of-life care, probably not surprising, and I deal with advanced directives quite a bit, in the sense that if people had them, it would make my job so much easier. And very few people have them, and so when we get into those dilemmas that you heard about, it can be very difficult, and sort of sussing out what that patient would have really wanted without any documentation, without ever having had a conversation, that gets pretty challenging. I have no conflicts of interest. I always have to say this working in a medical school. I have not convinced any pharmaceutical companies to pay me money to do these kinds of talks. It's really sad. So unfortunately, no conflicts of interest. So I wanted tonight describe some of those ethical challenges that our providers and surrogates face when they're implementing their advanced directives, evaluate how ethical challenges with advanced directives are commonly resolved. So how do we work it out when there is that conflict? And what are some strategies we can use to create effective and clinically useful advanced directives? All right, so you heard a little bit of this history from our panel. The classic case is actually Nancy Cruzan. She was a 33-year-old woman who got in an automobile accident. Like Karen Quinlan, she was in a permanent vegetative state, and her parents were able to remove the ventilator because the Quinlan case had established that that was okay. But she had been in this state for a very long time, and they also wanted to remove her feeding tube. And providers said, ugh, okay, the vent maybe, but the feeding tube, we can't possibly do that. And so there was a long court battle. You might see it sort of young white women who get in accidents. These are the cases that make headlines, and this is what changes the law for whatever reason. So her family advocated. The court said, we need direct evidence that she would not have wanted this feeding tube. Did she ever say that? I said, well, no, she never said that we can remember. He said, well, unless somebody comes forward to say that she said that, we can't withdraw it. So, of course, some very nice friend says, hey, wait a minute, she said that to me. Whether she said, I don't know if she really said that to her, but they decided that then it was okay. And after this, they developed the Patient Self-Determination Act. This was the idea that you need to tell all hospitals and all long-term care facilities and nursing homes need to inform patients that they have the right to write down their wishes ahead of time, and they have to provide you with those documents if you want them. So since 1991, we've had this. Every time you go to the hospital are informed of this, whether you realize it or not. It's probably buried in all of that paperwork that they make you sign when you first are admitted. So you have been told that this exists, and yet so few people continue to do it. Okay, so, but people realize that it's important, right? So something like 95% of people who are critically ill can't make their own decisions when they're in the hospital. 50% of nursing home residents can't make their own decisions. So lots of people need these documents to help. Somewhere between 20 and 30% of people will actually fill them out. So not a great percentage. But they don't seem to match up, so our inability to do this, or an unwillingness to do this, doesn't seem to match up with what we say we want. So 60% of people say they don't want to be a burden to their family making a tough decision about their medical care. 60%, that's a pretty high number. but 56% have not communicated their end-of-life wishes to any member of their family. So we say we don't want to be a burden, but we don't actually communicate what that means. 80% of people want their doctors to talk to them about end-of-life care, what that would look like, what context would it come in. Only 7% of people have ever had an end-of-life conversation with their physician. Yikes. So maybe our physicians need to be doing better as well. 82% say it's important to put your wishes into writing. So 22% do it though. So everyone thinks it's important, very few people are doing it. 70% of people say they want to die at home. 70% of people in the US will die either in a hospital, a nursing home, or a long-term care facility. Yikes. So it doesn't seem that what we say we want at the end of our lives or in a medical situation is really what we're getting. And it's partly because we're not doing the things necessary to get there. Oh, so let me ask you, you heard some of those reasons, but what do you think are really the top reasons that people don't fill out advance directives or don't have these conversations with their family members? You can shout them out, yeah. Okay. Yep. Yeah, we don't like to talk about the end of our lives or dying. It's a little morbid. Other reasons. Yeah, absolutely. So it's not comfortable to talk about death. It's not the thing I want to bring up ever. Yeah. Absolutely. I don't want my family to fight about this. If I bring it up and they don't actually agree, I don't want to be part of that. Better I'm unconscious and then they'll fight it out. Yeah. Absolutely. So we're afraid of dying, and we all know rationally that filling out an advance directive does not mean you're going to die within 72 hours or anytime sooner, but still, there's something about that fear that prevents us from thinking about it.
Is there any statistics that if that's different in people who work in healthcare?
Yeah, so people who work in healthcare have much higher rates of filling out their advance directives. I don't know what the exact percentage is. I know it is higher.
Okay.
Yeah. Yeah.
And some people feel that if they put their wishes down, that they can worry about care being withheld.
Absolutely. So this is big in organ donation documents too, but still with advance directives, people feel like, man, this will be an excuse to limit my care. If I say anything that kind of sounds like maybe I wouldn't want something, it's going to be denied to me. Better to write down nothing and assume that I'll get everything. That's not a good assumption, but it's one we might have. Yeah. Yeah. Where do these documents exist? I mean, you guys got them when you walked in, so you're like halfway there already. But if you don't know where to get it, how do I know? And apparently I was told when I went to the hospital that I can get these documents, but I never really saw that. I signed 10 of those documents and I never read them, and I didn't really realize I could get that.
I think another big factor is people will say, my family does what I want, or they'll say, my doctor will take care of it. I'll leave it to the doctor, they'll make the right decision.
Yes, I hear this all the time. My family will know what I want. They'll just know. Because they know me. It's a really lovely assumption. It's a really faulty one. Family members are slightly better than chance guessing what you would want. We might as well be flipping a coin. Or my doctor will know. The problem is, if your doctor always knew, jobs like mine wouldn't exist. So if doctors always knew the right thing to do for you, we wouldn't ever have these sort of problems, right? But they don't. It comes to a point where it's just very uncertain what the right move is. And doctors these days want to do what you want. They don't want to just do what they want. There was a time in medicine where it was very paternalistic. Doctors could say something and everyone would just say, okay, well, the doctor knows best. I'll do whatever the doctor says. That time has passed. If anything, doctors are terrified of making important decisions that might end your life. They don't want to do it. They don't want to ever go against what a family member has to say. they practice very defensive medicine. So sometimes it's a faulty assumption to assume that your doctor would just either know what you want or make a very strong recommendation that everyone would agree with. This is really not the current state of healthcare.
Some people think that it's the same as a will, and they think I don't have a lot to worry about in terms of assets, so I'll just do it later.
Mm-hmm.
They continue to be attorney.
Absolutely. So you think you need an attorney because for the other kind of will, you're a will of a state. So when your belongings, you do need a lawyer for something like that. So they assume they hear living will maybe, or they confuse it with the other kind of will. So they think, I don't have much to give away, so they conflate those two wills. Or they think, I need a lawyer. And then they think it's expensive, and I don't really have money for that. And as you learned, you actually don't need a lawyer. You only need 2 witnesses to say that you were of sound mind when you sign that document. What does of sound mind mean? I don't know, it's not written in the law. It just basically means like you weren't totally unconscious or you didn't seem like a lunatic when you signed it. And as long as I can say, yeah, those things seem true, then that's all you really need. So those seem like pretty good reasons, or not good reasons, but plausible excuses. These are the sort of top percentage reasons people say. It's emotional, it's morbid, only necessary if you want to limit care. So some people think these documents are only important if you don't want some care at the end of your life. Not necessarily true. They're too young and healthy. I don't need it now. I'm not dying. It's important to remember, and I don't know if this was emphasized enough by me or the last panel, in Michigan, an advanced directive applies anytime you don't have decision-making capacity. So anytime you're in the hospital, if you were in an accident or you have dementia or for whatever reason, you can't communicate what you need to communicate, these apply. So it's not just at the end of life. It's anytime you don't have the capacity to tell us what you want. They're too complicated, they're too expensive, but the number one reason is people don't know they exist. They have no idea they're out there, and you say, why don't you have one? They say, I don't even know what you're talking about. That's always the number one reason. So now you don't have that excuse anymore. You picked one up, you're here today, you know they exist. Okay, so some of the challenges to these documents, even if we have them. So they're often misinformed, unfortunately. So if you got one off the internet, you sign it, you fill it out, you didn't have a doctor talk to you about that document, you didn't have one of these specialists, one of these respecting choices folks, somebody who's trained in how to fill one out, you might fill it out and not actually understand what it really means. So something like 1/3 of people think you can talk with a ventilator. So has anybody ever sort of seen someone with a ventilator? I know all of the people in scrubs, certainly. So you would know that. Most people don't really know what these technologies look like. Have any of you ever seen CPR performed? Yeah, a lot of you. Okay, so more than the average person. People think CPR, they watch the movies. You know, you drown and you get CPR and then you jump up and you say, oh my God, thank you so much. I'm gonna continue on with my marathon, which is just absolutely not how it happens. If you've seen CPR performed, it is incredibly violent. It is probably gonna break some of your ribs. It, in the hospital, almost never works. So it doesn't have a very high effectiveness rate, but in the hospital, we always do it unless you tell us not to. It's sort of the presumed mode of care because, you know, if we're not sure, we'd rather err on at least trying to save your life. But people have no idea what these things mean, and so they fill out their advanced directives often with some misperceptions about what those technologies or interventions really look like, what they're for. So that's a problem with some of them. And then how effective those treatments are going to be. We're not so sure about that either. So unless you're doing it with a doctor or with somebody who knows how to fill it out, you might not already know what all these sophisticated medical technologies do. Why would you? You watch Grey's Anatomy, you kind of think you have a sense of it, and it might not be true to reality. Not denigrating Grey's Anatomy, it's an awesome show. You shouldn't plan your healthcare around the scenarios though. So again, sometimes they're a little vague. So I pulled up, this is just, if you Google Michigan Advanced Directive, this is what comes up. So even though it is, as we heard before, a durable power of attorney for healthcare, so really it's a designation form, it gives you this lovely bit here where you can say anything you want. So you can write, at the end of my life, I only want green M&Ms at the side of my bed. We will not honor that, but you could write it down. You could write down anything here. So that kind of helps us get a sense of what you were thinking. You have, your document hopefully has, is not, this one is, it's the sort of state document, but it's not particularly helpful to write in whatever you want. And it only gives you so many lines, right? That's exactly as many lines as the document gives you. You could sort of put an addendum in there. If you use something like 5 wishes, you'll have some more things spelled out. So if you were ever to have permanent and severe brain damage and you're unlikely to recover, would you want life-sustaining treatments in that scenario? Would you want them if you were ever in a coma? Would you want them if your healthcare provider thinks you'd have a short period of life and life-sustaining treatments would only delay your death? Okay, so those are kind of specific. They're still pretty vague, though. So that sort of checkbox might tell me a little bit of something, but it only takes one person in your family to say, no, 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 that's not what she meant. I was there when she filled that out. She was thinking of something else, to sort of derail that whole process. So this might help you to get thinking about the kind of scenarios in which you'd need an advanced directive. They're not necessarily always the most helpful when they're actually needed. So again, we know that not all of them are informed by a physician guidance or a healthcare provider is helping you to understand it, so sometimes they're misinformed. I teach medical students they follow around certain patients through 3 or 4 years in medical school, and they have to ask them about their advanced directives, and every year somebody says, oh yeah, I have an advanced directive. Have you given it to your doctor? Oh, no, it's way too personal for that. And so they don't really realize that if you have it, you actually have to give it to your doctor. And with the EMR, it is a little bit easier now to sort of upload it into your medical record. And that would be great if our hospital EMRs were the same. But guess what? They're not. Every hospital I work in Michigan has a different EMR. And they often have to like print it out and rescan it into the new EMR. It's just the least efficient thing you've ever seen. Technology in medicine, like IT stuff, is pretty behind. So we can't assume that if you went to a different hospital, they'd have it just because it was on file at your hospital. So all these kinds of issues make it difficult. So I'd say like make 10 copies of it and keep them like everywhere. Keep one in your car, keep one on your person. I don't know. Just keep one, give one to all of your friends. Spread around the wealth because you never know like where you're going to be exactly and when it's going to be needed. But certainly give it to your doctor. Unfortunately, studies show that at least surrogates will tell us that after the patient died, about 1/3 of them will say the physician ignored that advanced directive. Yeah, so that's a little disturbing, or at least didn't follow it exactly. So whatever they interpreted that document to be saying, they don't think the physician cared. So get a really good advocate who's going to be confrontational because it is really important. And often they're only pulled up when a patient is in crisis. So I have been called to many of these sort of ethics cases where they're saying, you know, either the patient really took a bad turn or we just really want to like stop this because we think it's too much at this point. Let's see if they had an advanced directive. So they only even care to look for it in the event that something's going very badly, which shouldn't be how we're doing it, but it can be how we're doing it. It's also, in some EMRs, really hard to find, which is terrible, but sometimes it's hard to find when you really need it. Okay, so this is the language when you appoint your patient advocate. You should also know that if somebody appoints you as that advocate, you actually have to like agree to it. We're not just going to make you do that if you don't want to do it. All the time, people appoint somebody and they never even tell them, which is pretty bad. You should at least tell your advocate. So we're calling people and they're like, what? She appointed me her advocate? No thanks. You actually have to sign a document agreeing to be the advocate. So just to guard you, you don't have to be anybody's advocate if you don't want to. But I gotta say, in these documents, sometimes it is, not sometimes, I'd say it's not very difficult for a family to interpret the document differently than the healthcare providers. So somebody writes down, I would never want to be a burden. I don't think I'd ever want a feeding tube. We get this one a lot. I would never want a feeding tube. And then the family says, well, I know that's what she said. I know that's what she wrote in this document, but that's not really what she meant. She imagined that she was on her deathbed and we were trying to feed her, and she knew that wouldn't work. But she's not on her deathbed. She's in a different scenario. And we think in this scenario, she really would want that feeding tube. And who are we to sort of disagree with that? That's hard. It's a sort of an interpretation of the document can be difficult. They're not self-interpreting. If a family can tell us a really compelling reason why it seems like the patient wouldn't want the thing they said they wanted in that document, it's hard to fight with that. So we ended up having these long conversations, but they can be overridden by family members. They're not supposed to be, but it's all about that interpretation. So what we really want to do is do what the patient would have wanted, and the family can tell us, no, that's not what she meant. She meant something else. Continue on with the treatment. That's going to be pretty convincing. So again, a good advocate is a good idea. And unless you've had a conversation, they're only slightly better than chance at guessing what you would have wanted. Sometimes even if you've had the conversation. One conversation is not enough. Yeah?
Do you find that placement issues, placement in the nursing home, long-term care facilities affect that decision-making as far as feeding tubes, etc.?
Yeah. I have stories. I don't want to like totally disturb you, but yeah. But yeah, so a lot of times people will say they never wanted a feeding tube, but they get one in the nursing home, and then they come into the hospital, and we're like, why are we replacing her feeding tube? She said she never wanted one. Eek. So, and then we have to figure out what happened there, which can be very distressing to our healthcare providers. It's unfortunately not all that uncommon for people to come in with treatments that they said they would have never wanted. Nursing homes like to put in all that stuff. Or they don't like to, but they often do. Yeah?
So, in case they're, for the word confusion, if I were to do this, should I be as literal as possible?
As literal as possible.
Like, like you said, like, for example, like, oh, you're in a coma, but you're not in that bed. Should I be like, hey, in case of a coma, or should I print out another sheet, type it out, and specifically say, just in case it doesn't work out, should there be a plan B?
Yeah, I mean, as specific and literal as you can be is always going to be better. Again, though, you're never going to predict the way you die or the way that you get into those final moments. It's so hard to predict how that's going to happen. So there's never going to be anything that's foolproof. You're never going to be able to write your manifesto that we can like, okay, page 23, he had this scenario imagined. Man, if you had one, we would try our hardest, I promise you. We want to figure out what you would have wanted. So if you can be specific like that, that's helpful. I've recently been doing some research on people in minimally conscious states. So people who are not in vegetative states, sometimes they can perceive what's going on, sometimes they have limited communication. And we really struggle with whether those advanced directives should apply to that case. Because they're not in that unconscious state. They're not permanently vegetative. But is this, so is this the state they imagine they wouldn't want a feeding tube? They're not dying at all. And that's a very difficult case. So we haven't really resolved that, except that some states have said, no, that doesn't count. They have to be like either dying or in a coma or in a vegetative state. So there's other kinds of states. It's just hard to imagine what might happen. But I think, yeah, as specific as you can get, that's going to be more helpful than not. It's never going to be unhelpful to be too specific. Yeah. Okay, so other problems that we sort of theoretically debate in bioethics, and they're somewhat related. So we call an advance directive a use of precedent autonomy, meaning we want to honor your autonomous wishes, so the things that you want as an independent decision maker. But we're worried sometimes when you don't have decision-making capacity, but your life seems okay. So the classic case is somebody who is moderately demented. They no longer have the capacity to make their own decisions, but they're like super pleasant and their life seems okay. So, you know, you wake up in the morning, you say hi to your friends, you sit in the park, you enjoy the sunshine, you're always smiling. Your life seems okay. And then your kids come in and say, Mom wouldn't have wanted to live like this, take away all of her end-of-life technology so she can die. And you go, gosh, maybe she wrote that, but is this what she was imagining? Is this the life that she thought she wouldn't want to live? We know that people are very afraid of certain things at the end of life. The number one thing is incontinence, which, I don't know, it is and is not surprising to me. I mean, sure, that would be a bummer. I don't think I'd rather be dead than have somebody wipe my butt. I don't think so. But a lot of people will say that. Gosh, if I were ever incontinent, just let me die. Like, ugh, is that okay? That's extreme. Or there's such a fear of disability that people sort of say things, and then if they could have only imagined what it was like to be in that scenario, maybe they wouldn't think that anymore. So what do we do with those folks whose lives don't seem so bad, but wrote advance directives that lead us to believe that maybe they wouldn't have wanted any end-of-life care and it'd be better for them to just be able to die? Those are tough scenarios. So they happen with dementia and then these disorders of consciousness. In a disorders of, like in PVS, you're not necessarily dying. In a minimally conscious state, you're not dying. But maybe you have a quality of life that you wouldn't find acceptable. But maybe you would. It's really hard to know that. So these get sort of borderline cases. I also would say that if you ask people, okay, here's what you said you wanted at the end of life, but if your family was terribly distressed about going through with that, would you allow them to make a different decision than you wrote down? Most people would say yes. Most people care about their families enough not to want to distress them, right? But we have no room for that in an advance directive. An advance directive is about me and my choices, and you have to follow through with them. But in what other scenario in your life is that how you make decisions? Screw what everybody else thinks, this is what I want to do, and you will abide it. At least not with your loved ones, right? Not with the very people you're asking to carry out these decisions most of the time. So is that the right way to think about an advance directive? Is what I want and everybody else just has to do it, even if it's terribly distressing and burdensome on my family? We also know that they don't necessarily decrease family stress. So making decisions for somebody that might lead to the end of their life is incredibly distressing. And you'd hope that advance directives would be able to lessen that stress. It does for some families, and it doesn't for others. If you disagree with what that person said they would want, that's a distressing thing to carry out. So it doesn't necessarily decrease that, and it doesn't really allow for the sort of family input. Well, my mom said she wouldn't want this, but I really want it, and I know if she could talk to me, she would agree with me. We don't really allow for any of that to happen in these conversations. Okay, so some fun new challenges. This was a case in the New England Journal of Medicine a couple months ago. Maybe you saw it. A guy comes in to the ED with the paramedics. He's had a heart attack. They rip open his shirt, and he has a DNR tattoo. It looks just like this is the actual tattoo, and you can't see it because it's blurred out there at the bottom, but that is his signature below it. Wow. What do? So you say, don't do it. Don't resuscitate him. It's a pretty clear wish, right? I got it tattooed on my chest. Come on. It's sincere. Yeah? Okay, you're the healthcare provider, though. And you're like, oh, you're that ED physician. Are you going to do it? It clearly says not to. Say that again? Oh, why do I need it in hand? It's literally written on my chest. Yeah, maybe it's pen. Oh, you need a witness. Damn it. He needed 2 witnesses, right? Yeah, we need the tattoo art. Did he really sign his own chest? I don't know. That seems hard. I'm not a tattoo artist, though. But who knows if it... So we actually don't even know if it was his real signature. Sure does look like it, though. And it's a tattoo, so it's definitely sincere. They resuscitated him. Damn. As good of an idea as it was, this isn't going to fly. Yeah. Was he up? Yes, he was very upset.
What if he has that and like one of those DNR documents, kind of period where DMR when you actually found it, and it was like, in case of instructions,
Yeah, CEMR, like a footnote at the end of that. That might have helped. The problem is that if you are rushed into the ED, we don't have time to look up your advanced directive necessarily. Yeah. We do, and you're anticipating a couple slides in. But because this doesn't count, they were more afraid of him dying and this being a joke than they were of resuscitating him and having him be really pissed off that we did that. So, I mean, that's sort of the gamble you have. If we had known that this was... Also, a DNR is a physician order. It's not necessarily an advanced directive, right? So your physician actually has to write an order saying not to resuscitate you, and this tattoo didn't necessarily cut it in terms of what's required. But bioethicists went nuts. They're like, oh, you should definitely abide this, or oh no, you definitely can't. It's not enough. Like, what if you just got drunk and just tattooed a DNR on your chest? We're really gonna let you die because you got drunk once and did something really dumb. So it's just hard to know how to sort of interpret that, though it seems like he probably meant it. He probably did, but it didn't fly, unfortunately. So if you thought this might have helped your situation, not yet anyway. Here's something that might help better. This is a My Post. This is brand new, hot off the presses. Our legislature just passed this. A lot of other states have it. These are traveling orders. So some of those orders that only your physician can write, this is like an advanced directive on steroids. This is something that your physician also has to sign, and everyone has to abide it. So that paramedic has to abide it. The nursing home also has to do whatever it says. Anyone who's potentially going to administer end-of-life care has to abide this document. And so that might help in some of these cases. There are some issues with it. So because it is a physician order, physicians were a little nervous about passing this. So there's a lot of reasons it might be revoked because they didn't want to necessarily be on the hook if something happened that they weren't in control over. But it's one step closer to having a document that is going to be sort of used and upheld in a lot of different scenarios. That's one potentially positive thing we can do. But then, okay, so then there's all these wrongful life cases, which was just brought up. So a lot of physicians for a long time have been practicing kind of a defensive medicine, meaning, you know who's not going to sue me? Like the person who I saved their life. They're probably less likely to sue me. So I'm just going to do it if I'm unsure what the right thing to do is. I'm just going to treat and treat and treat because that's just going to get me sued less often. I don't know why they think this. I always try to tell even my med students are like, are they going to sue me for that? Like, I don't know. They could sue you for anything. It's America. We can sue our physicians for anything we want. You shouldn't, and you won't usually win, but we can. But now patients are suing when they have these kinds of orders, so either a bracelet or a My Post or some other kind of document saying they wouldn't have wanted to be resuscitated. And if the physician or whoever's on the scene does it anyway, knowing that it's not what they wanted, you can now sue them for wrongful life. You didn't want to be saved. And they're winning these cases. There's been a lot of cases of late that have been successfully tried in favor. So then that physician or that physician practice has to pay for all of the medical care that will result from that, which might be the rest of your life. However long you live after that, somebody's going to have to pay for that care because you didn't actually want it.
And you sue your parents if you never wanted to be born?
You can. They are very, very hard to win cases, but yes, you can. And you can also sue your doctors if they didn't tell you some sort of problem that that your fetus might have had that would have caused you to think about termination. So if they don't tell you the kind of necessary information, and then you can sue your parents for forcing you to be alive. Again, very difficult. I think there's maybe been one successful case like that ever, but it does happen. Yeah, can you imagine as a mother suing the doctor for wrongful life of a child that is existing? Like, that must feel kind of bad, I would think. So you should also know, okay, so states are a little bit different. I will say generously, there is never going to be a scenario where I say, this advanced directive is from New Jersey, meaningless. Like, we don't do that. Like, even if it's from a different state, it's still very important and informative. Any evidence of what you might have wanted is going to be important because we just want to do what you would have wanted. So state documents being different, yeah, you should, if you are a snowbird or somebody who lives on a state line, you probably should look at the differences between those states' directives. We're not going to ignore them. But there are some states that have very specific requirements. So in Michigan, you have to acknowledge that your patient advocate could make a decision to stop treatment, and that decision might mean that you die sooner, which kind of seems like duh. But you actually have to sign a special place, and so hopefully it's in your document. You have to have this wordage, because we had a lawsuit, as all good things happen. And so this was sort of the Coalition on the Right to Life, making sure in Michigan that people really did understand that what the consequences of these decisions were. In Missouri, where I used to be, because of that Cruzan case, you have to sign a special box allowing somebody to take away artificial hydration and nutrition. That's typically considered just a standard end-of-life therapy. In Missouri, it's a special box. So you've got to make sure that if you live in a state that has sort of one of those special requirements, that you're abiding that. There are some states, too, that I said generally these apply whenever you lose decision-making capacity. That's not true in every state. There's a couple states, I think it's Florida and New York, where they only apply if you're in PVS, a coma, end of life. Like, they have certain parameters in which they count. You probably don't have to worry too much about that. In most states, they're pretty general, but in Michigan, you have to make sure that whatever document you fill out has this exact box, or your patient advocate can't make any decisions that might end your life, which is a pretty big obstacle if that's actually what if you would have wanted to limit treatment. When was it added? Ugh. It's been in there a while. It's older than 10 years, but that's a good question. If it's, then I think it has to be there. So if someone had an older one that before this was passed into law, I don't think we wouldn't follow it. We have to have this exact language in there. Yeah. So this is like a super important box. Our hospital, I won't name it, made like 500 5 wishes documents without putting this in there. And we were like, sorry guys, you cannot hand those out. That would be a real disservice to anyone filling it out to not have that really important box in there. Oh, good. I figured it was. Okay, so what can potentially help us moving forward with making sure that the documents that we have are working. So again, you heard this before, but people who are trained in respecting choices, that Gunderson model, there are all these professionals now who are trained to help people fill them out. And that is boosting how many people actually do fill them out and how informed they are. So that can be really helpful. There's all these national programs like you heard talking about death at dinner. It sounds kind of morbid, but I don't know if you've been following politics lately. I'd rather talk about death than that. So I'd say now's like a really good time to say, Thanksgiving, let's talk about death. Seems way better than other things we could talk about. I'd say this is something I run into quite a bit. Physicians don't necessarily always sit down with families and say, here's what we're doing and here's what the goal of that care really is. And so families don't really necessarily understand why they are saying yes or no to all these technologies because they don't really know what the purpose of them is. So our physicians need to be doing better with that. And I think us being advocates, constantly saying, what is that for? What is this going to get my mom out of the hospital? And if they can't answer that, then there's a problem. So I think always questioning, my goal is to have my husband go home with me. Is this getting him there? That's such an important question. So whatever the goals are for that treatment, you need to constantly be asking, is this going to get that person there? So I also, we just started reimbursing healthcare providers to have these conversations. Yay! I think that that's a really good thing because it can take a long time, and the average patient-physician visit is like 7 minutes, which is pretty sad. That's about as much time as your doctor's ever going to have for you. It's even less in the ICU. So let's start talking about it and reiterating it all the time. And if we can pay our providers to have the conversation, that's good. That's that death panel thing that everyone was worried about, but it's actually like a really good thing to pay our providers to talk to you about what you'd want at the end of life. I also think there's some leeway that might be built into these forms. If you ever would say, if you're having a really hard time with this decision, I grant you leeway to not follow my directive exactly. There's ways you can write that into an advanced directive. If you don't feel that way, I know many people feel like, nope, my family will do what I ask exactly, and I don't care about their feelings because it's my body at that moment. That's fine, but I think some people don't feel that way. So how do we build that in? I'm also working on a project where we're trying to do mass surveying of people to ask what kinds of treatments they would want in the event that we have somebody who doesn't have an advanced directive, but they're like other people. So we'd do enough survey data to say, men like your father, they're Caucasians, 70 years old, moderately demented. We've done mass surveys, and it says that they don't want vents at the end of life. So if you have no idea what your father would want, we might have some evidence about what people like him, people who say that family is the most important thing to them, people who have a particular religious faith. If we can collect all that data, we might have some evidence about what other people like that patient would have wanted, and that might be helpful, given how few people continue to fill out advanced directives, even though we've put billions of dollars into promoting them. So there might be other ways we can start thinking about how do we get evidence, how do we get sort of persuasion of folks when they don't know what to do. Okay, so I want to stop there to see if you have any questions. Yeah.
What do you think about changing the terminology do not resuscitate to the AND of unnatural death?
So some hospitals do that, not the ones I work in. It hasn't really seemed to solve many of the problems around do not resuscitate, although I think the switch of language, because it is the only treatment that we presume you absolutely have to have unless you tell us, or we have really good reason to think it won't work, or you tell us you don't want it. It's the only treatment like that, right? So it is that kind of this weird anomaly. So I think that language can be helpful to families who think do everything is the right option. Like, what would your dad want? He'd want you to do everything. Well, what does do everything mean? Would he want a natural death? Yeah, he'd want that. So, it might sort of introduce vocabulary that gets you thinking differently about that treatment. I think that could be one thing it does.
Who are the groups in the state of Michigan that you see will take up the role of educating around milepost implementation?
My guess is it's going to be the same folks who do the advanced care planning stuff. Is that what you mean, like who might be educating us? Yeah, I mean, they were integral in passing that legislation, and so I think they're going to be integral in teaching it too. So I think it's going to be those same people who are trained in advanced directives really want the MyPost to happen, because it's a little bit more security in those end-of-life decisions.
I don't think physicians in general, both in community-based practice and the inpatient side will view MyPost.
I think most physicians are in favor of this. I think they get really nervous because it's their signature, it's their liability insurance that is traveling around with somebody who's not directly under their care anymore. So that puts them in a precarious position. So I think on the one hand, you want to, and this is a problem we have all the time in my job, is we finally get to a place where we're saying we're not going to do these things at the end of life. Everybody, we can kind of more or less get people to agree, and then they go to the nursing home or the LTAC and they just do that thing. And so there's no consistency when you go to an outside facility. And then we get them back 3 days later, and we have to start the whole thing over again. And the family's upset. Everybody's upset. We're upset that they're coming back every 3 or 4 days because the outside facility won't agree with our plan of care. So I think for that, it's going to be really helpful. And so for those physicians, especially ICU attendings, I think they're going to like this. But again, it's just a little bit of trepidation about it being new and about their signature being on it. Ooh, that's a great question. I do not know the answer to that. Does anybody know the answer to that? There is the repository where we're keeping everybody's advanced directives in sort of a place where a lot of hospitals can have access to them, which is a great idea, right? My guess is yes. This is so new, though, I just don't know. Yeah. I think it's out there. Yeah. Yeah. You can fill it out online. Yep. Within just like the last couple months. So they passed it over the summer, and it took a long time to figure out what the language of the actual document should be. But it's out there. Yeah.
One of the things that you didn't bring up, like you have a background on it, is religion. And I was just wondering, what role do people's religious background play in making advanced directives? Are people, in general, people who are more religious, less likely to have one, or vice versa? And should that be a consideration with your religious beliefs in making?
Yeah, that's a great question. So we know that, I'm not sure as it directly applies to advanced directives, but Christians are much more likely to request aggressive care at the end of life, which is like surprising because of a people who are supposed to be like anticipating some great reward after death. They really struggle against death. So we know that there are certain populations that struggle more with this. There's certain religious populations that don't agree with some terminology around death. So our Orthodox Jewish populations don't agree that brain death constitutes death, things to keep in mind when working with them. I don't want to make too many generalities, but we do know that especially with Christian populations, they tend to be wanting more aggressive care. I deal a lot with, and have written about requests for aggressive care with the hope that a miracle will occur. This is like fairly common, is people think, if I just have enough faith, God will grant me the miracle I need to recover from this, or grant the miracle to my loved one. And physicians get real nervous about religious language like that. They're like, well, I don't believe in miracles, but what do I can't deny God, so I guess I'll just do whatever they say, instead of trying to engage what miracle really means for that person and how we can sort of work through, well, what does it mean and how do you know you found it? and sort of a genuine sort of questioning of that. That isn't, your miracle theology is stupid, which I've heard physicians say too. I used to work as a chaplain. I always found that trying to argue people's theology at the end of their lives is really dumb. It's just like not the best place for it. People tend to hold on to those beliefs really firmly at the end of their lives, and to argue with them about their faith beliefs makes them distrust you, and it doesn't actually help. But so entering into those conversations, I think, is the only way that it becomes productive. So do any religious groups have more advanced directives than others? I don't know that, but I do know there are some groups who ask for more aggressive end-of-life care.
You mentioned collecting data, like making a database. How are you going about collecting all of that?
Yeah, so we're in the initial processes of this, and this it angers some people, so I'm happy to talk about the ethical challenges of even this. We're in the process now of just surveying physicians and people who've had to make these end-of-life decisions, whether they would have found that kind of information helpful. And if we can show that they would have found it helpful, then we can start doing sort of mass surveying of public. We're going to try to focus on dementia, so moderate to severe dementia, what people would have wanted in those clinical scenarios. But first we just got to see if people would even think that this kind of information would be useful. So, yeah.
I think I heard you mention that physicians now can bill for having these discussions. So I'm wondering if that is going to affect possibly just regular family practice physicians blocking off a period, 10 minutes with each of their patients. I know that their time is precious, and we all know we have to wait a long time to see them anyway, but I mean, is this something now you can call your doctor's office and say, hey, I want to come have an advanced directives consult, and that can be an appointment? Is that a new thing now because of that?
Yeah, you can do that. I don't know how it's going to, that's also pretty new, so I don't know that there's a lot of data yet on how that's influencing those interactions. Some of the problems are, though, that even primary care physicians don't necessarily feel comfortable leading these conversations, and so there's still some education that needs to happen there. So there's like palliative care docs, hospice docs, they're very comfortable with these conversations generally, but our primary care physicians aren't always. They don't really know how to start that conversation. We're doing training now with med students to teach them how to start those conversations, but I think that's going to be a learning curve. So even if they can get reimbursed, they don't know how to have the conversation.
Don't you think some of that comes from a misconception, though, that people think their doctors are going to be caring for them at the end of life? That almost never happens.
Yeah, that's so true. So I've even had to make sure that ICU attendings are calling PCPs because they never think to do it, even though it's like right on the banner of their EMR. It's like right there, and they never think well, who's to say what she would have wanted? I don't know, maybe that PCP who cared for her for 40 years might have some idea about what she would want. We almost never call your PCP in those intensive care situations, which is sad, but true. So yeah, don't assume your PCP is gonna be intimately involved. And some just don't have time. They're not rounding at the hospital. Sometimes I hear PCPs just say I can't believe that she's in the hospital right now and nobody called me. So it's true, they're not always there.
One of the things I was reading recently was a patient saying, well, it was a patient advocate saying, I don't think my father would want to spend so much money at this end of life to live the quality of life he's had. He was really kind of cheap. I mean, I like to think money shouldn't be an object, but is that something that you could say, hey, I don't want a lot of money spent when I have a low quality of life?
Absolutely, you should write that in. And that's the right way to say it if you're a patient advocate, is he wouldn't have wanted us to spend all this money. Because as soon as you say, it's too expensive for me, we get real nervous. As you know, which makes sense, right? We don't want people saying, oh yeah, let him die because it's too expensive and I want the inheritance. We're really worried about that. We don't want to listen to you if you say that. But if what you say is, he wouldn't have wanted to sort of bankrupt us all in order to live 3 more weeks. That's really reasonable. Unfortunately, I seldom hear that, but it's got to be true for so many families. It's just very, very expensive, and not all of our insurance is paying for it. Sometimes families don't know that until they get the bill later, and then they go, wow, if I had known it was that expensive, we might have thought differently. But I think that's a perfectly appropriate thing to consider. Who among us would want to bankrupt our families to have just squeak out a few more days? Probably not many. That's why social workers are great, because they're pretty good at knowing like what things are costing and where you can be placed and how insurance works. Our physicians don't know that, but our social workers often do. Yeah.
How do you think it's not going when, we've had family members say, you're my oldest child, you're going to be part of the thing, or our spouse saying, you're the next of kin, it's all on you, but yet they don't want to do documentation because they think it's already good.
So if it's your spouse, we will probably turn to that person if they absolutely refuse to sign one of these documents. It's definitely more important if you think, like others said, your spouse wouldn't be the person, or if you're unmarried, if your parents would make bad decisions, by all means choose somebody differently. But we will typically turn to a spouse even though there isn't a next of kin. So if you do trust that person, that's who we're going to go to. We're not going to try to sidestep your spouse because we don't have documentation. That person probably knows you the best, so that is who we will turn to. So I'd say if they don't want to fill out the documentation, you can work on that, but having the conversation, knowing that if you are the spouse or you are the parent or the sibling who would naturally be the person that somebody would call, the oldest sibling. If you have a bunch of siblings and they don't all agree so well, I'd love to say that this rarely happens. It happens all the time, and it might be because I'm a clinical ethicist and I get called into the hardest scenarios, but man, does it happen all the time that the family just doesn't agree, and then it becomes very protracted. So do it if there's any question. If you have a spouse who really loves you and knows what you would want, the documentation is going to be helpful, but not as helpful as the conversations would be.
Can you tell us a nightmare story and how you resolved it?
A nightmare story and how I resolved it. When I lived in Tennessee, we had a lot of cases because in Tennessee, your physician gets to choose the person. There's no next who would be the appropriate decision maker if you didn't have one. So all the time it would be, I have this wife, but we're estranged, but I have this girlfriend. And then there was a lot of live-in girlfriends and estranged wives scenarios where you have to sort of weigh like, oh my gosh, but the kids want to go with the mom, right? But the girlfriend definitely knows this guy best. They've been living together for 10 years. She'd probably know, but then the family is like, they don't care for the girlfriend because, you can imagine, she's not the mom. And then there's a lot of fighting. Honestly, I think the person who knows the patient best is the person who should be making those decisions. And sorry if that cuts out important members of the family. We could do that easily in Tennessee because of the way the law was written. I just had a case where it was a very big Catholic family, and matriarch of the family is dying, and they're trying to decide how to extubate her, whether it would ever be appropriate. They're totally disagreeing. They finally come to a resolution, and then a new brother flies in and just like won't have it. And then starts yelling at the physician, who starts yelling back. It was a nightmare. Don't yell at the physician, but also if you're a physician, don't yell back at the person yelling at you. It just escalated it quite a bit. And then, you have to call security, and that's never fun. So I think the hardest cases are these family fighting cases. Or I get called all the time because the treatment actually just isn't working, and it's futile, and we have a very specific policy about futility. And the family just cannot see that this treatment is only hurting this person, and it actually in no way is benefiting them. It's physiologically not working. Those are the hardest cases because they feel like we're killing that person, and we feel like we're torturing them by continuing treatment. Those to me are just the most difficult emotional cases. because we don't want to take away somebody's loved one, but we also don't want to torture somebody with treatments that aren't working, because they are burdensome. So in my work, I'd say lately, 80% of the cases I get are physicians are saying, it's just not working, we got to stop it, and the family is saying, absolutely not. You are murdering my loved one right now. And there's a lot of murder language that they know how to sort of tug at the heartstrings. Those are the toughest cases lately.
I bring up religion because we have an all-Catholic system for the most part here.
Oh, right.
Does that, does the Catholic system or other similar ones affect advanced care planning, how it's done?
In that, so I used to work for Catholic healthcare as well. The stuff around PVS is particularly difficult because the Pope John Paul II made a particular pronouncement about the necessariness of feeding tubes for people in permanent vegetative states. That has been interpreted to mean that we're never allowed to withdraw them, which actually isn't what he said. And his own feeding tube was withdrawn at the end of his life. So, but there is still some confusion around when it's ever appropriate to withdraw feeding tubes in Catholic hospitals. I think that becomes a particular sticking point at end of life. But most Catholic hospitals will have some organizational ethics person who will take on those cases to answer them specifically using the ethical and religious directives of the Catholic healthcare systems. Those are very important books if you've never read that. So 1/3 of all providers will work in a Catholic healthcare system at some point in their career. So understanding the differences in Catholic healthcare is really important. There's just some things that you can't do in Catholic healthcare systems, and some ways you have to think differently about the care provided. Yeah, in most places. Yeah. I think it just depends on your bishop and how aggressive he's going to be about monitoring the hospital care. But in most places, it's not a big deal. It just, every now and then you hear of these sort of cases where the bishop got interfered and determined that something was inappropriate or demanded that certain kinds of treatment. So usually it's not a big deal. There are always some cases where things get brought up. But that's a good point. Most of end-of-life planning and care is not different in a Catholic healthcare institution. All right, I don't want to keep you here all night, but I'm happy to answer questions if you have any more after. Thank you.